Thank you so much, and I really want to thank Bobby for that excellent presentation. I can tell you from firsthand experience, I'm a hospital doctor. I work in the ICU. I work with end-of-life care, and I support everything that he spoke about. I do want you to know that there are doctors out there who are fighting for life. I fight for ordinary means of delivering hydration, nutrition, medication to patients every day. And support your friends, your colleagues that are doctors, because some of them feel like they're on an island out there. So we can go ahead and start my presentation. Do I have a clicker? Okay. Yes, I've been fortunate enough to be a medical advisor for Priests for Life, and they were very involved with Terry Chavez's case and supporting the family through that and trying to fight for allowing her to receive nutrition and hydration there at the end of her life. Thank you, Georgette. Okay. Thank you. So this is just a list of the things I do, and one of the most important things I do is I'm able and fortunate enough to be a teacher, and so I'm an assistant professor for students, and so it's very important to have pro-life physicians in the community and in medical schools teaching pro-life medicine to up-and-coming physicians. So in 2006, I was in my practice seeing patients, and I got a call late in the morning, that a young woman had come into a local crisis pregnancy center, and we have relationships with our pregnancy centers around the Charlotte area. And she had just taken the RU46 abortion pill 36 hours prior, and she had regretted it. She came home, she told her mother. They really had no idea what to do, so they went to the crisis pregnancy center, who then called me and said, what should we do? And of course, I didn't know either. I said, just come on over to the clinic. So she came over to the clinic. She had taken this pill. She had not taken the second medication, and we'll explain the process in a minute. But she wanted to do whatever it took to save her baby. Well, in our office, Danny Holland, who is my partner, was a Creighton fertility model practitioner. We use progesterone to ethically support infertility problems, and we were able to successfully have lots of women achieve pregnancy and carry pregnancies to term using progesterone supplementation in their pregnancies. So we happen to have progesterone in the office. Well, the way RU46 works is it's a progesterone blocker. And so we kind of deduced that if we give more progesterone, try to outcompete RU46 at the progesterone receptor site, and essentially put more good medication in there to help her, we could hopefully outcompete that RU46, the abortion pill, and we could reverse its effects. And so I told this to the young lady. I said, this has not been done before. We don't really know whether it will work or not, but we know that progesterone is safe, has been deemed safe for use in pregnancy for now probably close to 40 to 50 years. And it's been safe in seeing that there's no birth defects for the babies. So we felt like it would be okay to use in this situation. And she said, I'm ready to take it. I want to do whatever it takes to save my baby's life. So we gave her I gave her a progesterone shot that day and hoped for the best. This was on a Thursday. So Friday night, we get a call that she was starting to bleed, and we thought for sure that we had lost the baby. So we told her to go to the emergency room. We knew the emergency room physicians there. We knew that they would support her and they would support our plan. Fortunately, they got to see a heartbeat, and she had not seen the heartbeat earlier at the abortion clinic because they didn't let her see it when she went to get the abortion. And she told me later that if that was the only thing that she got out of it, it would have been worth it to her to see her baby's heart beating. But the emergency room doctor said, and the emergency room doctor could have said, in this pro-death culture, listen, you're going to lose this baby. Let's go ahead and do a D&C. I'll call the OBGYN. But he didn't. And he said, I know Holland and Harrison, and I believe in their plan. And so he said, go home and hope for the best. She did, and she stopped bleeding, thankfully. She came back into our office Monday. We were able to reconfirm a heartbeat. She stopped bleeding, and we continued to give her progesterone supplementation following the protocol that was initially set up for fertility treatments. And 40 weeks later, little Kaylee was born, and Kaylee is now 15 years old, perfectly healthy, doing great, and Ashley has been a great advocate for this procedure. So in 2007, the very first abortion pill reversal baby was born, and I want to show the next slide is going to be a little video. And this is going to explain the process a little bit better. Now, there's some cartoon images, no real-life images, but some of them are a little graphic, so if you want to close your eyes and listen, that's fine too. But we want to see if we can show this video. Just the first 2 minutes, please, to save on some time.
My name is Dr. Anthony Levatino. I'm a practicing obstetrician-gynecologist, and I performed over 1,200 abortions. Today, I'm going to describe a first trimester medical abortion. This is a procedure in which the mother swallows pills in order to terminate her baby, and it is performed up to the 10th week of pregnancy. The procedure involves 2 steps. Step 1. At the abortion clinic or doctor's office, the woman takes pills which contain mifepristone, also called RU46. RU46 blocks the action of a hormone called progesterone. Progesterone is naturally produced in the mother's body to stabilize the lining of the uterus. When RU46 blocks progesterone, the lining of the mother's uterus breaks down, cutting off blood and nourishment to the baby, who then dies inside the mother's womb. It is important to note that even after it has been taken, it is possible to reverse the effects of RU46 and save the baby if progesterone is administered. The sooner, the better. Step 2. 24 to 48 hours after taking RU46, the woman takes misoprostol, also called Cytotec, that is administered either orally or vaginally. RU46 and misoprostol together cause severe cramping, contractions, and often heavy bleeding to force the dead baby out of the woman's uterus. The process can be very intense and painful, and the bleeding and contractions can last from a few hours to several days. While she could lose her baby anytime and anywhere during this process, the woman will often sit on a toilet as she prepares to expel the child, which she will then flush. She may even see her dead baby within the pregnancy sac. At 9 weeks, for example, the baby will be almost an inch long, and if she looks carefully, she might be able to count the fingers and toes. After she has disposed of her baby, the woman may have bleeding and spotting for several weeks. Bleeding lasts, on average, 9 to 16 days. 8% of women bleed more than 30 days, and 1% require hospitalization because of heavy bleeding. The failure rate increases as the pregnancy progresses. If failure occurs, she will usually be offered a surgical abortion. For the mother, medical abortion often causes abdominal pain, nausea, vomiting, diarrhea, headache, and heavy bleeding. Maternal deaths have occurred, most frequently due to infection.
And just to review real quickly, a medical abortion is when you take RU46 up to 10 weeks pregnant, 70 days after the last menstrual period. 24 to 48 hours later, Cytotec is given either orally or vaginally to induce contractions. And then the patient passes the fetus and products of conception at home. Bleeding can last for up to a month. Retained products of conception can lead to hemorrhaging or infection. And the effectiveness of doing the 2-pill regimen is very effective, 94 to 98% in women that are less than 8 weeks pregnant. And as Georgia has spoken to you earlier, the number of medical abortions or chemical abortions is really rising over the surgical abortions. And there's even newer data that says that 43 to 45% of all abortions are now chemical or medical. And the problem is we're probably not even counting all those because there are many doctors that are prescribing the medication and it's not even picked up on any of the statistics. So this is becoming more and more prevalent. And just to kind of point it out here, the decidua basalis is where all this is occurring, where the RU46 works and where the progesterone also works to fight against it. So in the reversal process, we give 200 milligrams of an injection, as soon as we can after they have taken the RU46, we try to perform an ultrasound just as soon as possible to first make sure that the baby is in the uterus and not an ectopic pregnancy outside of the uterus, which can be dangerous and deadly for the mother. And then we repeat 200 milligrams injections for 2 more days, and then every other day until day 14 after the ingestion of the abortion pill. And then we treated with progesterone, 200 milligrams twice a week until the end of the first trimester. Some women did not like shots. Some doctors did not have access to the injectable medication. And so as we were collecting data over the next 10 years, we found that if women took 400 milligrams of the prometrium or progesterone orally or vaginally, they were still getting excellent results. And we'll go over some of those numbers. Just a quick cartoon here. This shows what an agonist and an antagonist is. An agonist is what progesterone is. It blocks other things from getting into the receptor, but it gives you a full effect of what that chemical and what that receptor is supposed to do. A partial antagonist or a partial agonist will come in, will not give you the full effect, but it'll activate the receptor, but it'll also at the same time block other medications or activators from getting into that site, okay? The way that RU46 works is that it is a complete antagonist. It blocks the receptor, there's no effect, and this is why the baby's, the decidual basalis starts to dry up, the placenta separates away from the wall of the uterus, and then the women cannot get the effects of the progesterone. So just another quick cartoon. If this is the uterus, we have the good keys that are in green. They're unlocking the yellow locks. RU46 is the black keys that do not activate it, and so they will block those receptors. And then if you give extra progesterone and good keys, that's the goal of our treatment, to activate these receptors. So Dr. George Delgado then contacted me in 2011 and started to, wanted to get together information about all the people from around the country and the world that were starting to do this protocol and save babies. So he produced this with Dr. Mary Davenport. It was 6 case studies that showed us that this is something that we needed to look at further. About 2/3 of the women ended up having successful, healthy deliveries. So then we started to collect more data. He brought me onto his team, where I was kind of the East Coast person, he was the West Coast person, and we got lots of more data of women that were taking this protocol. Over 750 women entered the study. 547 met criteria for inclusion because some were lost to follow-up or had changed their mind and went back and got abortions, and so of course we would take them out of the studies. Overall reversal rate was about 50% in groups using the injectable progesterone. But again, the women who used oral progesterone or injectable and completely followed the protocol exactly like they were supposed to, 64 and 68% effectiveness rate. And so many of people that are opposing us were saying, oh, well, if you do nothing, then you'll get the same result. But this is not true. So we did a literature search and review and found that only 7 to 21%, maybe 23% of women carry a pregnancy to term successfully if they do nothing and just don't take the second pill, which is a lot less than our 68% who were having successful pregnancies after progesterone or supplementation. And if they don't believe it, these are just some of the results. And as Georgette had said earlier, over 3,000 babies have been born, with over 300 mothers still in the protocol currently. We have got reversal inquiries from 50 states, 65 countries on 6 continents, and have had successful reversals virtually everywhere. And now we have over 1,100 providers worldwide that are ready to deliver this reversal. So currently, progesterone is FDA approved for treatment in pregnant women. We have a 2,500 member AAPLOG which supports this procedure. It is safe for mothers and babies, and women do change their mind after getting an abortion. So how do we deliver this process? We have teams outside of abortion clinics offering help. We have billboards. We have mobile ultrasound units that can actually carry progesterone medication at the sidewalk. As soon as they walk out and have had an abortion procedure, we can start the process reversing it right away. And then people access the protocol through pregnancy resource centers, doctors, the hotline, and friends that know the system. We have mobile apps that women can access when they look up, what do I do to reverse an abortion? So we have also worked with 13 states to put legislation out there requiring informed consent. So when women go to get an abortion, they have to receive information that says, if you change your mind, you can call this number and talk to them to see if you're a candidate for getting a reversal. And the pro-abortion community hates this because we have gotten quite a few calls from these states, women changing their minds. And the future holds that, as you know, in 2021, the FDA announced that it will be lifting restrictions on telehealth abortions, very, very dangerous procedures. Women are very far away from any medical help or medical resources. They take a pill that is unlocked so they can take it right there in the office. And many of these people are going to have ectopic pregnancies, are going to hemorrhage and not have access to blood products, hospitalization, or rescue procedures. And it's extremely dangerous. So we already have processes and protocols that are coming into place to provide safe, effective telemedicine reversals. We need to make sure that these women have viable pregnancies that are not ectopic pregnancies, and just contacting them so that they can get the medical help they need and get out of that remote area is very important. The first thing we do is do no harm, and I'd like to wrap up by thanking my biggest support system, my family. Appreciate y'all pulling this conference together. Thank you. I'll be available at the break for any questions. Thank you.